Aloha everyone, thanks for joining us again today, Tuesday, May 12th, 2020. Hope everyone got our announcement about the time change, just trying to make sure we can accommodate some of the schedules for both our attendees and presenters who are getting back to work or who have been going to work all this time. We're going to continue with health and safety, our second part. And we are being rejoined by most of the team. Kalkamau unfortunately had to take care of some things, but we'll get her back in the next session. Last week we did talk quite a bit and in depth on a lot of issues around COVID-19, coronavirus, some of the things going on in the world and how it's affecting voyaging specifically. Today we're gonna focus a little bit more on specific health and safety around voyaging itself, a lot of the things that we take into consideration in training and prep, and I'm actually just going to hand this off to either Dr. Tamura or Kelly.
Kelly,
yes, perfect.
but you know what? I don't know how to share my screen now.
Okay.
Lots of things. Hold on. How do I get back to?
I will stop sharing my screen and then I think you can.
Oh, maybe that's why.
Okay.
Oh, no. Oh no. Sorry. I know you're not seeing my screen, and I want you to see my screen. I sort of lost you. Hold on. There we go. Okay. And okay. Sorry, guys. I'm going to get this going, I promise. Okay. Screen share. There, and
no pressure.
Yeah. Sorry, I apologize 100%, but I can't get rid of this. Maybe that's what.
Yay!
You see it now?
Yep, we see your screen.
All right, there we go. Okay, all right. Okay, so today's talk, our meeting is going to be mainly about health and safety. We are going to mainly talk about health and safety for the crew members. Okay, so it's the talk next week is going to be more about health and safety for the person, for just your overall health. His overall health is going to be the talk next week. But this week, we're mainly going to talk about health and safety when you're actually a crew member on the voyage, okay? So I want you to keep in mind, essentially, that the information that we give today will be applied to everyone, kind of as a one-size-fits-all. But I want you to also keep in mind that you will also have your own things to worry about personally. So voyaging is actually an extreme sporting event. And the reason why we say that often is because of its geographical isolation. Now, the physicality on the boat occasionally will be very physical, but a lot of times it won't be. So in that sense, it's not necessarily an extreme sport, but the isolation makes it very dangerous. We had a previous crew member that was a medical officer, and she actually worked at Everest Base Camp, and she used to say that being on the canoe in the middle of the ocean was more isolated than being at Everest Base Camp. So the other issue we have with being on the canoe is that we have limited resources. We don't have a lot of electricity. We don't have a lot of technical resources. So many ailments that on land would not necessarily be a big issue become very big issues on the ocean, and can be life-threatening medical emergencies whereas on land they wouldn't necessarily be. So in order to help alleviate this and help improve sort of the situation and make things as easy as possible or as safe as possible, there's a couple of things we need to do. 3 things in particular. We need to prepare. There's limited medical support on board, so we want everyone to sort of prepare for the possibility of there being an emergency. We want people to realize that everyone has their own specific issues and try to prepare for those specific issues. We want people to be vigilant while they're on board. We want them to prevent things from happening. That means not showing off and not trying to put yourselves in situations where that could lead to a medical emergency. And then once we sort of get a handle on all of these things, we want people to practice, experiment with their own individual therapies on land before going on the voyage. Okay, so we also want to talk about the idea that there's no I in crew. Okay, so being a crew member is a privilege, it's not a right. It's not about you, it's about everybody else. So because of that, we want taking care of your health. Because of that, we want people to take care of their health, because essentially we don't want, if we have to take care of you on board, that means that we could possibly be putting everybody else at risk. Okay, we don't want to put anybody else at risk, essentially. So we want you to know yourself, know your issues, know things that could possibly go wrong, and try to prevent that. Know your limits, know what you can and can't do, know your weaknesses, and also know your strengths. Okay, so today we have an agenda today of certain things that we're going to go over. So the first things we're going to go over are common health issues at sea. We're going to go over sail clearance. We're going to go over, we're going to go over pre-existing conditions. We're going to talk about we're going to review some previous events at sea. We're going to talk about some tropical medicine issues. We're going to talk about some protocols for emergencies at sea. And then we're going to talk about protocols for safety on land. And then we'll have some closing comments from our leadership. Okay, so I'm going to turn it over to, I think I'm turning it over to Dr. Tamura.
Or the Seren.
Oh, Seren, are you doing common issues at sea?
Yeah.
Cool.
I will abbreviate what I have for you guys in a big way. You got to stop sharing your screen now.
Oh, how do I do that?
I got you.
Yeah. Did I stop sharing it there?
Let's see. I'm sharing my screen now.
Hey, Bruce.
How's it?
How's it going?
Good.
Hi, Bruce.
Calling you back.
You all good for tomorrow?
Wait, am I sharing my screen? Is it working?
We got you.
Yep.
Yep.
Okay. All right. I'm apologizing in advance. This is basically a lumped together 10 lecture series. So I will abbreviate it. We're going to skip a lot of slides. There's going to be a lot of clicking. I do not expect people to be reading all of this information right now. And like you guys are going to notice throughout this entire talk, all of these themes, all of this content will be given again and again and again ad nauseum so that we can really get people prepared. So certainly we do pull aside the voyaging crew right before voyages and reinforce this information and present it again. So that is when we will go into a lot more depth. This is just kind of more of an introduction and an overview than anything else. But since I had exhaustive slides prepared, I just threw them all in here and we'll just go through them pretty quickly. So basically, let's see, health and safety curriculum for voyaging crew. So we've started creating a curriculum that does take 3 full weekends. The goal was really to raise the bar with our safety and health competency, with the goal of just increasing information and training to minimize risk. We're hoping that we increase the understanding of common conditions so that we can increase people's ownership over their own health and safety. A healthier and safer crew member equals healthier and safer crew. Okay, so this is a pretty exhaustive slide that basically shows what we are running through for our voyaging crew, with every crew prior to them actually taking part in a sail. And so on the left side is the medical sort of topics that we'll kind of be going through. The right side is the water safety sort of things that Archie Kalepa is really championing. And we've actually done one set of sessions of these already. So with our crew that was anticipating going to this year prior to COVID. So what we've got, oh, sorry. So these are just some pictures that I stole from Sam's Instagram about this first sort of session that we had. And it was great because really what we ended up doing was demonstrating to ourselves and each other sort of where our physical fitness was, what our health competency was. We did a lot of learning. We floated around in the ocean for a really long time. But this is all part of the general health and safety sort of training that we want to be able to do for all of the crew. All right, so in looking at the overview of the MEG curriculum, the first 5 were things that we went through already with that first group. So this will be a big review for them in a lot of ways. And then the final 5 were the things that we were going to include in our last session that we didn't quite get to. We started doing this actually while we were actually on a canoe. So this did come out of a necessity for, again, increasing people's baseline knowledge, as well as if your medical officer falls overboard, I hope that everybody else knows how to take care of them if they're not able to participate in their own care, at least to the extent of stabilizing them and getting more people involved so that they can get definitive care. Okay, so we'll just jump into it. GI, we're talking about constipation as a pretty common thing on the VAA. So generally described as having less than 3 bowel movements a week, chronic constipation being infrequent bowel movements or difficult passage of stools that persists for several weeks or longer. These are just the medical definitions. If you can't poop, you're constipated. Constipation meds are one of the most utilized meds on the VAA, actually. Constipation on the VAA most often caused by a combination of several different things, but the big ones, namely being a change in diet, being that most of the food that we have on board is a lower fiber content because it is in processed form so that we can store it for a longer period of time. And then behavioral. Some people don't like to poop around other people. We do have a medical term for that, but we call it shy bowel. All right, so treatment for constipation really depends on the underlying cause. It begins with diet and lifestyle changes. So diet and lifestyle changes, basically increasing fiber intake and exercising. So moving around really does increase the activity of your intestines and allows transit of your poop. We brought lots of crew mooing on our voyage. Shy bowel sort of problems, can't poop in public. Don't ignore the urge to have a bowel movement. Take your time in the bathroom, allowing yourself enough time to have your bowel movement without distractions or feeling rushed. Practice makes perfect. I think Dr. Ben Tamura actually has a system where he prepares himself to poop in less than ideal conditions prior to leaving for his voyage. So I'll let him share that with you at some point. Let's see, we have medical medications to treat constipation as well. Laxatives we have a lot of different laxatives. They all work a little bit differently. This is one of those that I don't need you to read all the words for. But we got fiber supplements, we got stimulants, we got osmotic laxatives, lubricants, stool softeners, enemas and suppositories. So lots of different options. I think one of the important things with the constipation is to let us know as soon as possible if it's something that you're suffering with so that we can try to address it as quickly as possible. The sooner we get to these things, typically the easier they are to address. The longer they go on, the more challenging it becomes to take care of them sometimes. All right, we'll talk real quickly about seasickness. So seasickness is this type of motion sickness. Any sort of transportation can cause motion sickness. The more often you travel in general, the more easily you'll adjust to being in motion. But that's not always true for everyone. This is a slide that shows us on the medical side what goes on. There's a lot of words. Basically, the take-home message is that there's a motion stimulus. That was from our voyage on a pretty decently sized day. And that information is processed by sensory organs that exist in different places that are responsible for telling your body where it is in space. And so these receptors exist in the eyeballs, in the ears, and in the muscles. And basically that information gets processed in the brain, and then that happens when there's a mismatch of information from these different locations. Okay. Seasickness, you might be able to avoid motion sickness by planning ahead. So if you're susceptible to it, there are a couple of things that we encourage people to do. Things like looking at the horizon, positioning yourself where there's least amount of motion, keeping your head still, avoiding strong odors and other triggers. Ginger is a supplement that we often try for nausea and vomiting. We ask people to eat lightly, taking it easy, so not exerting oneself too much. Staying hydrated is a really important thing, especially if you're vomiting, in order to try and prevent dehydration. And bland foods. So avoiding sort of fatty, spicy foods, alcohol, those sorts of things that can increase sort of that nausea factor. All right. There are over-the-counter motion sickness medications. So antihistamines, scopolamine patches are some things that we see pretty frequently. But just similar to constipation, it is something that we do better with if we're able to try and tackle it sooner. The longer it goes on, the more challenging it becomes to sort of address it. So please communicate with the medical officers. Let us know if this is something you are experiencing, so that we can try and take care of it as soon as possible. Major danger in seasickness is dehydration. So we do start getting worried if someone is profusely vomiting for more than 2 days, for an adult generally. I do think we talk about dehydration later, so we can kind of move through that. Rashes are another thing that we were asked to discuss as common sort of conditions on the va'a. So skin rashes can occur from a lot of different factors, lots of different factors. Infections, heat, allergens, immune system problems, medications will be some of the things that we'll be going over. The goal for me, actually this was more for our prior talk, but would be not so much to know rashes exhaustively, but be able to kind of try and identify the type of rash so that we can figure out how to treat it appropriately. So these are some pictures of hives. There's a medical name for it. We call it urticaria, but they can be triggered by a lot of different situations and substances, including exposure to certain foods and medications. We don't need to talk about angioedema, though it is a potentially life-threatening complication that does occur sometimes. Let's see, so causes, foods, medications, airborne allergens like pollen, environmental factors, medical treatments, and sometimes people with underlying conditions will tend to develop hives more frequently. But a lot of times we can't figure out a specific cause. All right, complications. These are just some scary pictures of angioedema, where we actually get such severe swelling that we compromise airway, and this could be a medical emergency. Treatment for hives, mainstay is antihistamines, so Benadryl. All right, second rash is something called contact dermatitis. So really kind of two sorts that we're looking at there: irritant contact dermatitis and allergic contact dermatitis. And this is related to coming into direct contact with something that your skin doesn't like. Treatment really is to avoid whatever that is. So some people have nickel sensitivities or allergies, I guess, dermatitis that can develop with certain substances. And so the goal is really to just avoid those things that trigger these sorts of reactions. Heat rash is another sort of rash that we commonly see on the va'a. This sort of a rash occurs when the flow of sweat is obstructed. So we see this a lot when we're voyaging in the tropics, actually. Not a serious rash, usually resolves when the affected area cools. So cooling off the area, cool compresses can help. In order to prevent this sort of a rash, we encourage people to wear loose, lightweight clothing and avoid excessive heat and humidity, though that sometimes isn't possible when you're on a canoe in the middle of the ocean. Intertrigo is a rash that exists between folds, usually places where there's skin-to-skin friction on the body, so warm, moist areas. This can be a painful rash, actually. Skin can crack and chap, and we can also get high incidence of secondary either fungal or bacterial infections in these areas that are just really great breeding grounds for these sorts of pathogens. Usually this sort of a rash will clear up if you find a way to keep the affected areas clean and dry. So again, loose fitting clothing, powder sometimes helps to reduce that skin-to-skin friction. Weight loss is really helpful overall to avoid this sort of a rash or decrease the incidence of skin hanging onto skin and creating that sort of nice wet friction environment where this rash thrives. All right, fungal infections. So we can get fungal infections on our body. I think people are pretty familiar generally with ringworm. Treatment usually requires a prescription antifungal medication in order to clear some of these bigger rashes. These rashes can cause some discoloration that will take a while to resolve, even after the infection itself has been cleared. So that's not an unusual thing for color to sort of be off for 6 to 12 months sometimes following eradication of the fungal infection. You can get a fungal infection in lots of different places on your body. Call it different things based on where it's located. This is another rash that we don't actually see as commonly in Hawaii, although I just saw one the other week. If anybody is familiar with the beach, with Richardson's Beach up on the Big Island in Hilo, it's a beach that's surrounded by a lot of freshwater springs. There's a lot of ducks around there. But this swimmer's itch is actually a rash that's caused by a parasite. So we see this typically around freshwater ponds and lakes. This does bear some relevance to the talk, or to a couple talks from now, where I'm going to be discussing how to stay safe when you're actually on land as well. You need to know that that's just the life cycle and basically how these little parasites exist in nature and between their hosts. Usually not a serious rash, usually clears on its own. At-home remedies can be helpful to ease the itchiness, but it can be a pretty gnarly looking rash actually. Drug rash. So drug rash can occur as a side effect of taking a drug or as an allergic reaction to it. Usually will start within the first week of starting a new medication. Often begins as red spots that are pretty diffuse across the torso. Usually when you stop taking the drug that caused the rash, it'll clear up in a couple of days to weeks. Strains and sprains, so we got through rashes. Strains and sprains are another very common medical thing that we see on the va'a. Sprains are regarding ligaments, strains are regarding muscles, and essentially they are graded the same way though. So they go from being pretty normal to all the way ruptured, and we grade those based on how much of a tear stretch actually exists in the tissues. Symptoms can include pain, swelling, bruising, limited ability to move the joint. Let's see, ankle sprains are pretty common. Really all joints though can be sprained. Generally, the greater the pain and swelling, the more severe the injury is. Treatment. Rest. I think most people know that the RACE sort of treatment. So resting the injured limb, icing the area, compression, and elevation. Let's see what to expect. Sprains can take a really long time to resolve, as in months sometimes if it's a really bad sprain. I think a really big part of how to minimize how much time you spend down has to do with early range of motion and weight bearing as soon as it's tolerated. And that's really helpful to sort of regain function. Should feel a progressive improvement. Over-the-counter anti-inflammatories are really helpful for this. And prior to sort of full return, especially if it's a bad injury, restoring strength and stability is actually a really important thing to minimize further injury. This mechanisms of spraining something can also be mechanisms that could cause more serious injuries. So we have a little bit increased of a twitch factor if someone is not able to bear weight on the affected extremity at all. Let's see. Or if you actually have no improvement or worsening in that sort of past 48-hour period. We will breeze through the common cold because we talked about a lot of these things when we talked about COVID the other week. So basically, common cold is a viral illness. It's self-limited, meaning that it goes away without treatment. It's pretty common. Average person has about 2 or 3 colds a year. And these are caused by many, many different viruses, lots of different viruses, and they cause very similar symptoms. Transmission. Again, we'll go through this pretty quickly. Direct contact. Indirect contact, meaning that the virus survives on surfaces. Somebody else touches it and then introduces the bacteria to themselves, or the virus, I should say, or the inhalation of viral particles. That's why we wear masks right now. Increased risks of developing cold symptoms can occur with psychological stress, lack of sleep or sleep disturbances, I didn't put that in there, exposure to children in daycare settings, but increased severity of colds is often seen with underlying chronic diseases, immunodeficiency problems, malnutrition, cigarette smoking, and advanced age. I did make this talk pre-COVID, so I apologize that we're going through a lot of the same information again. There is an incubation period and symptom duration that varies for each particular virus. Some of these symptoms include runny nose, sore throat, sneezing, coughing, feeling ill, fever. I put in here purulent drainage because a lot of people will come in and talk to us about the color of their mucus that's coming out of their nose. And so you guys can stop saving mucus to bring into your doctors because it doesn't really tell us very much. So all of those are actually all viral boogers. So none of those were actually bacterial. Moving on. There are things that can mimic the common cold, so things like allergies, bacterial throat infections, bacterial sinus infections, whooping cough. I think this is where I'm supposed to give a PSA for vaccinations. But these are all things that can mimic the common cold that we would have to tease out and make sure we're not dealing with in order to be confident that symptomatic therapy is the way to go. So symptomatic therapy really is the only thing necessary for treating the common cold since it's self-limited. Antibiotics don't help with viruses because antibiotics are not effective against viruses. I'm not going through all these in exhaustive detail, but these are some things that we have to minimize or mitigate, I should say, the symptoms of a common cold. Things that can help with congestion and coughing and runny nose and all these sorts of things. So, all right, prevention. General hygienic measures. Hand washing is very important. decontamination of environmental surfaces. Take-home points. Common colds are common. Hand washing is the best way to prevent the spread of a common cold. Antibiotics aren't helpful for a common cold. Symptomatic management is important, and we have different options to treat different symptoms. Generally, I'll tell my patients that when they have a cold, my goal for them is for them to manage their symptoms as well as possible so that they can keep eating and drinking normally. And that being that because this sort of an illness is self-limited, you want to be as close to your baseline as possible, because even if you were totally fine, no cold, no anything, and you didn't eat or drink normally for a few days, you wouldn't feel very well at the end of the time. So really the goal is to get yourself as close to baseline as possible so that your body has the best chance of dealing with it as quickly as possible. Okay. Bleeding. Hemorrhage is a name for medical bleeding. The reason we're concerned about bleeding is because massive blood loss can lead to someone dying. Human body has about 9 to 12 pints of blood. We see pretty significant changes in people's blood pressure and heart rate after they lose about 30 to 40% of their total blood volume. So that would be considered life-threatening. Blood travels through the body in vessels. There's a lot of vessels that you don't need to know. They all kind of look like that. Capillaries are the littlest ones. They're about the size of hairs. Most bleeding is capillary bleeding and is considered minor. This sort of bleeding is usually related to scrapes and small cuts. And the type of bleeding that we see typically is slow and oozing. These are some examples of capillary bleeding. Venous bleeding. So venous bleeding comes from a venous source or from veins, typically darker in color. And we describe this sort of bleeding generally as oozing from the body. Veins are under lower pressure than arteries. So this is still the sort of bleeding that can typically be controlled with external pressure. But it can be threatening, life-threatening if it goes on for a while. So these are some pictures of venous bleeds. Arterial bleeding. So arteries are the muscular blood vessels, and so they're under higher pressure. Arterial bleeding, we typically describe it as gushing or pulsing bleeding, usually bright red in color. It's a lot easier for somebody to lose a lot more blood pretty quickly because of the sort of pressure that these vessels are under. That would be an arterial bleed. So pretty significant amount of pressure required to shoot blood that far. Most bleeding does look like a lot. We get really worried if somebody loses more than 30% of their total blood volume because it does put it puts us into a state of essentially hypovolemic shock or a very low blood volume shock. Let's see, how to stop the bleeding. So local pressure is usually adequate for capillary bleeding and small venous bleeding. It can take a while for a blood clot to form depending on the wound size. So holding steady pressure for about 1 to 2 minutes is usually pretty adequate. The tricky thing is that letting up on pressure to see how the bleeding is doing essentially restarts your clock if the bleeding has not yet stopped. So checking if it's still bleeding every 10 seconds is usually a pretty ineffective way to hold pressure to stop bleeding. Use of tourniquets is an important option for arterial bleeding, but it's really important that we only use these things in situations where it's absolutely necessary. Because stopping blood flow to a limb or to an extremity, essentially, if we can't restore that blood flow within a certain time, everything past that site of the tourniquet will be lost. All right, medical grade tourniquets do exist. We have actual tourniquets. I just didn't know at the time of making this presentation, so I decided to teach people how to do a field tourniquet, but it's not necessary. We actually have actual medical tourniquets available to us on the va'a. One very important thing to note, though, is that if you ever apply a tourniquet to somebody, the exact time that the tourniquet was applied should be noted. And that's because that is a really important factor in determining that viability of the limb once we do get them to definitive sort of medical help. There are chemical compounds that can encourage the formation of blood clots. They can be dangerous to use, though, so they should only be used when we're trying to control the severe life-threatening bleed. We do have quick clot, which is one of these chemical compounds that is available on the va'a. Okay, we don't have to go through all this. But basically, before we do voyage, we do go through this with our crew on overviews on how to stop minor and major bleeding. Very quickly, we'll go through broken bones and spinal injuries. So broken bones, a fracture is the same thing as a broken bone. It does require medical attention. Usually a broken bone is the result of a major trauma or injury. Just ask for help if somebody breaks a bone. The doctor should be well aware of that. All right, let's see. So broken bones on the va'a. Try not to move the person unless it's absolutely necessary in order to avoid further injury. But on the va'a, that does mean getting the person to a safe place, usually the central location, since they'll probably not be as capable of maintaining their balance on a moving vessel with a broken extremity. While you're waiting for medical help, stop any bleeding if it does exist. Try to immobilize the injured area. We're not asking for anybody to reduce or fracture or stick bones back under the skin, but splinting is something that we actually do cover in the health and safety lectures prior to voyaging. Ice packs and swelling can help, and always watching out for shock. Spinal injury. So if you suspect a back or a neck injury, definitely need to seek help at that point. This is one of those, don't move a person unless we've been trained in how to move somebody with a spinal injury. Just assume that this person has a spinal injury if there's evidence of a head injury with an ongoing change in someone's level of consciousness, presence of severe pain in their neck or back, weakness, numbness, or inability to move their arms or legs. If the neck or body is twisted or positioned in a really odd sort of a thing, maybe don't try and untangle them yourself until we make that assessment. All right, hyperthermia, hypothermia. Too hot, so hyperthermia. Kind of goes on a spectrum from heat exhaustion all the way to heat stroke. So these things can occur usually when playing, working in a heated sort of environment. Heat stroke does occur when your body temperature rises and you're unable to cool it down. It can be life-threatening due to damages to brain and other vital organs. Heat stroke causes. Exposure to hot environments are certainly one of them. Strenuous activity. In either sort of these heat strokes, condition can be brought on by wearing excess clothing that prevents sweating from evaporating easily and cooling your body. Drinking alcohol can certainly disrupt your body's ability to regulate temperature. And being in a dehydrated state does increase that risk of of heat stroke. Risk factors for developing heat stroke. Age is certainly one of them because the ability to regulate your temperature does depend on the strength of your central nervous system. In our very young and in our older populations, we sometimes see less robust ability for the body to accommodate drastic changes in temperatures. And both of these age groups historically just have a little bit more of a challenge in remaining hydrated, which does increase the risk. Exertion in hot weather is certainly a risk factor. Sudden exposure to hot weather, and we'll talk a little bit about acclimation or getting used to being in hotter environments. But limiting activity for a couple of days in order to acclimate to a very big temperature change is usually a great idea. Certain medications can affect your ability to stay hydrated as well as respond to heat. I don't have to go through all of them, as well as certain health conditions. So these are kind of things that, again, we like to talk about, because if you do identify with any of these risk factors, there are ways, especially prior to getting onto the VAA, to try and mitigate some of these risk factors or to minimize them as much as possible. Heat exhaustion signs and symptoms can include a lot of different things. Cool, moist skin, hot, dry skin, heavy sweating, faintness, dizziness, fatigue, weak, rapid pulses, thready pulses, low blood pressure, muscle cramps, nausea, headaches, heat exhaustion. So if we don't treat heat exhaustion, which is a slightly earlier version of heat stroke, it can be a life-threatening condition. So if we do suspect heat exhaustion when we're on the VAA, we typically take these steps in order to address it immediately. We move the person out of the heat and into a shady, unfortunately we don't have air conditioning, but into a shady location. Lay the person down, elevate the legs and feet slightly if you're able to. Remove tight or heavy clothing, have the person drink cool water, either non-alcoholic beverage without caffeine, and cool the person as much as possible while keeping a close eye for any complications. These are just more signs and symptoms of heat stroke. Fainting can be a presenting symptom, especially in older adults. If you suspect heat stroke, call for help. Get the person out of the heat, remove excess clothing, and start cooling. All right, too hot, prevention. So heat stroke is predictable and preventable. So we talk about these steps, at least considering these things to sort of try to prevent this from even occurring. So loose fitting, lightweight clothing, protecting against sunburn, because sunburn does affect your body's ability to cool itself. So you want to protect yourself from getting sunburned. Maintaining your hydration, drinking plenty of fluids, taking extra precautions with certain medications, taking it easy, not running around during the hottest parts of the day, getting acclimated. So again, spending some time, increasing periods of time, working in hotter conditions can help to acclimate people. And be careful if you're at an increased risk. Okay, too cold. Normal body temperature, usually around 98.6 degrees. Hypothermia occurs when your body loses heat faster than it can produce heat. Our absolute number that we use for that is typically 95 degrees. And if left untreated, this can be a life-threatening situation as well. That's Matatini. He apparently doesn't feel cold ever. All right, so we lose heat in a few different ways. We lose heat that's radiated off of our body. We do lose heat through evaporation, that's sweating, in order to cool down. Convection is when air passes by and takes heat away from you. So that would be the wind factor. And conduction is when you're directly in contact with the surface and you lose heat through that. So these are the major mechanisms by which we actually lose heat from the body. Let's see, specific situations leading to hypothermia. Wearing clothes that aren't warm enough for the weather conditions, staying out in the cold too long, being unable to get out of wet clothes or get yourself warm and dry, falling into the water as in man overboard situations, and living environments that are too cold due to poor heating and insulation. Okay. Risk factors for developing hypothermia: exhaustion. So your tolerance for cold actually diminishes when you're fatigued. Older age, again, we talked about the ability to regulate temperature. So that does become a little bit challenged as we do age. Very young age as well, with regulation of body temperature. Mental problems can increase your risk of hypothermia, as well as alcohol and drug use. and certain medical conditions and medications. All right, so signs and symptoms of hypothermia. Shivering, although that can stop as the body temperature drops. Slurred speech or mumbling, slow, shallow breathing, weak pulse, clumsiness, drowsiness, confusion, loss of consciousness. Here's where we see bright red, cold skin, especially in our infants. The confusion is an important part because a lot of times somebody doesn't realize that they're getting hypothermic, and it's other people that will realize that first. So being aware of the rest of your crew and how they're acting and doing is important in these situations. Cold water safety. Water doesn't have to be extraordinarily cold to cause hypothermia. It can just be a prolonged sort of exposure that does cause that. So we wear life jackets. We get out of the water as quickly as possible. If you are in cold water, or actually if you're just overboard, I guess, don't attempt to swim unless you're very close to safety, just because swimming will use up a lot of your energy and can shorten your survival time, especially if you don't know where you're swimming to. Position your body to minimize heat loss. I think I have a graphic that pops up, as well as the huddling. While you're actually submerged in the water, don't remove your clothes, because it does help to give you a degree of insulation. Once you're out of the water, we do talk about getting out of anything wet and cold as quickly as possible and getting warm and dry. Oh yeah, so this is a help position. So basically it's trying to minimize loss of body heat if you are submerged. So Archie makes us practice this when we go float around in the ocean, so everybody will get a chance to do this. All right, once we're back on the va'a, in a hypothermic sort of a situation, we move the person out of the cold. See, insulating, especially around the neck or the head. It's definitely time at that time to remove wet clothing and replace wet things with warm, dry coverings. And if further warming is needed, then that warming is done gradually. We have talked about hypothermic protocols if somebody does go overboard in a cold water situation on the va'a. So prevention is probably one of the most important things, and that pretty much should be a theme throughout this entire talk, is not just recognizing these things, but figuring out how to avoid even getting there. So we use this little cold equals cover, overexertion, layers, and dry sort of thing to remember this. So cover, keeping yourself covered, especially places that lose a lot of heat, like your head, face, and neck. Overexertion, so avoiding activities that would cause you to sweat a lot, because wet clothing and cold water often don't go well together. You can lose body heat more quickly when that occurs. Layers are very helpful, and staying dry as possible. And that does include hands and feet as being a significant source of heat loss and important areas to keep warm and dry as well. Oh, thank God, dehydration. All right, so dehydration occurs when you use or lose more fluid than you are able to replace. If you don't replace lost fluids, you will get dehydrated. You can usually reverse mild to moderate dehydration just by oral rehydration, but sometimes severe dehydration does need escalation of care. Dehydration causes, so diarrhea, vomiting, fever, excessive sweating, increased urination, basically any ways that you can increase your fluid losses and not replace them adequately. Risk factors. Infants and children, typically these are the guys that will experience dehydration after severe diarrhea and vomiting. Infants, you know what, we're not going to talk about infants. We're not taking infants on the canoe. Older adults. Older adults have less fluid in their body in general. May also have mobility problems, so that does contribute to an inability to actually hydrate themselves as actively as they may want to. People with chronic illnesses are at a higher risk of dehydration. Things like kidney disease, even acute illnesses, in a sense that if somebody isn't consuming as much fluids as they normally do because they have a sore throat or they're not feeling well, that can lead to a dehydration picture, as well as work physical exertion outside, especially in hot and humid environments. Signs and symptoms, so extreme thirst, less frequent urination, dark urination, fatigue, dizziness, confusion, and a faster heart rate are typically things that we see in dehydration. Dehydration can lead to serious complications, including things like heat stroke, like we're talking about, kidney problems, seizures, and shock. To prevent dehydration, prevention slide, drink adequate fluids, especially to replace your losses. So I know I grew up learning 8 cups a day. I think they've adjusted that at some point in time. So I think the last thing I read was 15 cups for the average male, 11 cups for the average female, but that does include water that's contained in foods. I'd say that water intake had to increase if people are in these sorts of situations where they're experiencing vomiting, diarrhea, or basically higher fluid losses, so strenuous exercise, extremes of temperature, or illness. Skin infections. Skin infections are, well, we're pretty physical when we're on the va'a, and anytime we break skin, that puts us at risk of getting a skin infection, so it's something that that we did want to talk about. So causes of skin infections are when bacteria enters disrupted areas of skin. So recent surgery, cuts, puncture wounds, ulcers, even poor skin quality can contribute or can lend itself for a setup for a pretty significant skin infection. So risk factors, injuries, again, any sort of breaks in the skin, weakened immune system, skin conditions, even things like eczema, athlete's foot, shingles, all of these things just give bacteria entry points. Chronic swelling or something called lymphedema is something that does put you at an increased risk of getting a serious skin infection because fluid's not moving normally and skin is is sometimes compromised. And obesity is a risk factor for developing more serious skin infections. Symptoms, redness, purulent drainage, swelling, pain, tenderness, warmth, fever, red spots or streaks or blistering around a wound are all things that would make us very concerned for a significant skin infection. Treatment for skin infections really is just with appropriate antibiotics. Once the skin infection is bad enough, the bacterial infection probably will not resolve without appropriate antibiotics. So prevention. In order to prevent serious skin infections, we'll talk about taking these precautions, washing wounds daily with soap and water as part of normal bathing, applying an antibiotic cream or ointment, keeping that wound clean, dry, and covered, and watching for those signs of infections, because again, the sooner we're able to deal with things, usually the easier. The longer we let things go, most of the time, the more challenging it becomes to end up taking care of it. Oh, I did put in this slide specifically, not necessarily for va'a, but people with diabetes and those with poor circulation or compromised skin or compromised immune systems do need to take extra precautions to prevent skin injury, to avoid skin infections. So especially with our diabetic patients, we always talk about inspecting their feet, moisturizing their skin, trimming fingernails and toenails, protecting their hands and feet with appropriate footwear, and treating any sort of infection on the skin very, very quickly and aggressively so that it doesn't develop into something more serious. That's all. Oh my gosh, we're done. Thank you.
Thanks, Doc.
No, Rob. Oh, should I stop screen sharing? Let's stop.
Okay, Ben, I think you're next, right?
Yep. Let me see if I can do this. Okay. Guys can see that? Yep.
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 Okay. You know, I was going to talk about our clearance to sale process. And then after that, Dr. Marge was supposed to talk about, you know, common pre-existing medical conditions we see in crew and how to prepare yourself if you're sailing with these things. And then she was going to review some of the major events we've had over the years and see what kind of lessons we can learn from them. You know, what about those events might have been avoidable or preventable, but she couldn't make it. And she did prepare something that she put a lot of work into. So what we're going to do is, rather than try and ad-lib her section, we probably will present it at another session. And we'll skip those 2 sessions. So you're going to hear 3 things from me in succession. Yeah, clearance to sale. Then I'm going to talk about pre-sale preparation. And then finally, I'll talk about some travel tropical medicine issues. Okay, so clearance to sale. You know, we've always referred to the pre-voyaging medical clearance process as crew clearance, clearance to sail. And I've been told that it makes some crew members nervous. Many see it as a pass-fail situation, and that's not what it's designed as. Although we call it a medical clearance process, without getting technical, it's not a clearance process. What we're really doing is a risk assessment. Put another way, what we're really doing is a medical risk assessment to participate safely as a crew member. And the goal of our clearance to sail process is not to come up with a yes or no, can or cannot answer. You know, we're not trying to weed or exclude people that have been invited to serve as crew. If you've been invited to crew, there is a reason behind that invitation. The captains and canoe leadership do not pick names randomly out of a hat. Everybody is chosen for a reason. If PVS wanted to exclude someone from sailing, they wouldn't have invited you in the first place. So when we go through our process, we have 2 goals. You know, one is what are the safety risks for the individual, because that translates into what is the safety risk for the crew in the canoe. And the second goal is, how can we help that crew candidate minimize avoidable risks given their past history, their medical history, in order to sail safely. So our outcome is not an on and off switch, it's more of a rheostat. Yeah, you go way down on one end and it's yes, you're low risk, go for it, you should be fine. And then way down on the other side is someone with high risk, something bad could happen at sea. You know, Captain, how much of a risk are you willing to take? And can we maybe make some accommodations so that this person can participate? So that's what our clearance to sail process is. It's not an exclusion process. Don't get nervous about it. So there are 4 principles that we use, so we're consistent, that guide our clearance to sail process. You know, number 1, all crew must be able to predictably contribute 110%, or others aboard may be harmed. Now, when we say 110%, what we mean is a crew member needs to have the capacity to do what they're asked, and if they sustain a minor injury, they're still able to function. So they sort of have that extra capacity that they can adapt to. It's not like, you know, a little bit of back strain and they're out of commission. They can't do their watches. So that's what we mean by 110%. You need to be in good shape. You need to be fit. Number 2, no medical screening process is 100% predictive of a safe outcome. You assume risk if you go on this voyage, and you have to be open about that risk with your family. In the event of a medical emergency at sea, our clearance to sail process is not a promise of a safe return, so much as minimizing the chances of an avoidable medical emergency at sea. Again, our clearance process is about prevention, and I'll talk about the medical supplies we bring and what the limitations are in a bit. The third principle is we need you to be open and honest about your medical history. Again, we're not trying to exclude crew candidates from going. If something is found of concern, our priority will be to involve you and work with you and your personal doctor to help you to qualify to go. And rule number 4, you know, for deep sea voyaging, a crew member must be able to stop all meds for 10 days without a life-threatening consequence. In other words, if you're taking a medication and that medication is abruptly stopped for whatever reason, will you be okay 10 days later, or is something bad going to happen in the interim? This is a basic concept that I got from my predecessor, Pat Ayu. And this has kind of always been in place. It's actually basic wilderness medicine based on a worst case scenario of you losing all your supplies and meds. If you are in an ocean wilderness and say something happens where all of the med supplies and your personal gear just gets soaking wet, none of it is usable. You know, the meds you brought that are very important get wet, and you just have to stop taking them, and it's going to be 7 to 10 days until we get to land or, you know, figure out what to do. If that person is on a critical med and it gets ruined, will that crew member off the meds have something bad happen within a week? I know it sounds harsh, but it's not meant to be. It's about safety. The classic example there is someone that's got a seizure disorder. They're stable on their meds. You know, something happens, the meds are ruined. We don't have the right meds. It takes a week to get replacement. You know, by the third day, they're going to just be in seizures in front of everybody, and we can't do anything about it. That's what this rule is all about. So sometimes the risk for someone serving as a crew is greater than the benefit to the canoe. You know, said another way, the risk of someone serving as crew is greater than the benefit to the canoe if the risk of a pre-existing medical condition interferes with duties or risks getting worse at sea. If that risk is better than the benefit to the crew and captain, that's where we sort of need to have a talk. You know, sometimes crew candidates can take on specialists or mentoring roles where they're not expected to do full watch duties. Again, our goal, if you're invited to sail, is to figure out how can you go to optimize safety. So our crew clearance process, like any pre-employment physical, starts out with a long questionnaire, and this is actually not a long questionnaire. But it's necessary. You don't complete the questionnaire, you don't get a call for crew clearance. This completed questionnaire is sort of our ticket to start reaching out to you. Depending on circumstances and time, an exam might be done. Your history, or what you tell us, is far more important than what the exam tells us. You know, your past medical history, what meds are you taking? What are your allergies? What's your family history? What's your past surgical history? Do you have any bothersome symptoms that might be suggestive of something we need to take care of? What are your lifestyle habits? Now, the questionnaire is only as good as you are honest and comprehensive in completing it. After we get the completed questionnaire, we review it in detail, and then we talk to you. That's when we clarify and get detail about what's flagged in the questionnaire. If we do have to do a physical, it's a fully closed exam that's customized to your medical history. It's not the kind of exam you get before surgery or something like that. It's really toned down and specified and includes a lot of mobility and musculoskeletal stuff. If we do need more information, we ask your permission, and we won't do it without your permission, but we ask your permission if we can pull in your personal doctor and get their opinion and help in, again, trying to figure out how can you adapt to what's going on so that you can sail safely. Now, crew candidates who are out of state or out of the country, you're going to have to go see your own doctor. Now, if you don't have one or you can't afford one, let us know. We'll figure something out. We have managed to figure something out. Worst case, one of our docs will talk to you long distance on the phone and get a sense of whether you really need to see somebody, or we can do something virtually and then manage it when you, come here or something. So, but again, crew candidates, if it's easier to just see your own doctor and fill out the forms, that's how it's usually been done. Fitness testing. Now, during the last worldwide voyage, PVS leadership started to include crew fitness testing as a basic part of their crew training, and it was genius. I don't know why we didn't do it before. And like the medical risk assessment, fitness testing is not conceived to exclude people. It's not a pass-fail thing. The intention of fitness testing has to do with the holistic health and wellness that goes beyond the canoe. The spirit behind this is to encourage and motivate you to be healthy and fit. Now, for the worldwide voyage, this is what we started out with, and it has since morphed depending on the captain and crew. Again, but this is what we started out with way back in 2013. 20 push-ups, 5 pull-ups, 10 tricep dips, something called a Turkish get-up. It's online, and that's more of a mobility test than it is a fitness test. unless you're doing it holding a 100-pound weight. We do a timed 1 mile walk. It has to be done in 15 minutes or less. That's a 4 mile per hour walk. That's 120 steps a minute. That's 2 steps a second, basically a fast walk. It's not a jog. And then finally, there's a 1 mile swim in 90 minutes. Again, these things may have changed, or there may be variations on these depending on the captain, setting and circumstances. But however the process changes, I think it's fair to say that in some form, this fitness testing is probably going to be a permanent part of all crew training accountabilities from now on. Now, failure to pass the test does not disqualify you. It signals the need for an action plan to help you improve your fitness so that you can possibly pass it in the future. It's the call of your captain, and it's something you're going to have to discuss with them. Again, we can help you. Each of these activities, by the way, can be trained for. Probably the most common one that people don't complete are the 5 pull-ups. Now, if you Google search, quote, how to do 10 pull-ups, unquote, you're going to get nailed with all kinds of websites that tell you how you can do a home training program over a month and learn to do 5 to 10 pull-ups. So again, this is something that you can train for. You can ask people for help. You can ask your doctor, physical therapist. You can ask one of your other crew members. You can ask us. But again, this fitness testing is not designed as a barrier. It's designed as an approach to wellness and overall general health and fitness. Okay, so after we do the questionnaire, after we talk to you, there's a physical, you go through the fitness testing. After everything is said and done, the medical logistics groups kind of meets and we go over each of the crew candidates. We review our findings and then we notify the captain and the appropriate PVS admin person as to what your status is, green, yellow, or red. Very simple. Green, full duty, no physical restrictions. Yellow, full duty, but some caution. You might want to consider a specialized role or limited watch duties, responsibilities, but still good to go. And then red. Red does not mean you can't go. You know, red applies mostly to deep sea legs, where the crew candidate has a significant risk, and that risk is felt to be greater than the benefit for all considered. So we talked to the captain, and maybe they should be considered for an alternate role, maybe an inter-island or a coastal leg instead of deep sea, unless that person is maybe in a non-physical role, a pure mentoring or teaching role. So that's basically what our clearance process has to do with. And it doesn't end here. There's still one more step, and probably the most important step for doing all of this. And that's creating a medical summary. So I took this guy's name off and I changed the age and made up some stuff. But this is basically a classic 65-year-old guy. After the process is all said and done, we write up a medical summary for every crew member, and that goes on record with the PVS office. It is treated confidentially, but it's necessary as a quick reference in case of an emergency at sea in the middle of the night. And that has happened. That has happened. You know, we're not going to talk to you on a sat phone and ask you, hey, what are you allergic to? You know, that's not going to work. We need to collect this before something happens. So again, everybody has one of these if you've sailed before, or at least in a worldwide voyage. So that's my med clearance talk. I'm see if Dr. Mao came on. I guess not. So I'm going to jump to my second part, which are health and safety preparedness. Okay, this section is going to focus on preparing to sail from the perspective of health and medical safety. This is not about man overboard drills, you know, fire alerts and stuff like that. You're going to get that in a separate talk. This is about how do you prepare given your unique health status and your medical history. First off, our supplies. Our med supplies are limited to 3 coolers per canoe. Now, we're stocked no better than a small primary care office practice. You know, we're limited not only by space and weight, but we're also limited by restriction inherent in being on a canoe. You know, we're not on a large Norwegian cruise vessel. I mean, this is a double hull canoe, basically a large Hobie cat. There's no electricity. There's no, so no equipment that requires electricity like cardiac monitors, IV pumps, surgical equipment, suction. We can't bring those things along. There's no refrigeration. There's no running water. We don't carry oxygen for reasons I won't get into. And we cannot do any kind of surgery. We can't do anesthesia. We can't even do conscious sedation. So we're very limited. It's basically primary care, office urgent care. Now, we do carry some broad spectrum intravenous antibiotics and some injectable meds. We do carry a supply of intravenous fluids, but most of what we have is oral, and these are not a big enough supply to last more than, the IV supplies. It takes up a whole cooler, and the stuff we got in there is barely enough just for 2 or 3 days. So again, we are limited by what we can bring. We cannot do more than basic life support. We cannot and we should not do advanced cardiac life support. We're not equipped to do that. We'll probably do more harm. So again, all that we can do is basic CPR and seek out help. That is the danger of deep sea voyaging, the extreme geographic isolation and limitation of supplies and equipment that can turn a treatable condition on land into something fatal at sea. An acute appendix at sea, more than 300 miles offshore, can be a disaster. An ectopic pregnancy. You have good bisex, and 1 week at sea, you get this severe pelvic pain, and you've got a ruptured ectopic pregnancy. That's a disaster if you're more than a couple hundred miles off sea. So again, that's why prevention and planning are so important. So preparedness, prevention, practice, know thyself. As Bruce said, 2 weeks ago, get used to the ocean, get in the water, get into the ocean as much as you can in your spare time, swim, surf, paddle, dive, snorkel, do anything, but get in the water. It does make a difference. So skin preparedness. I had much grosser pictures than this to show, but the one on the right I thought was pretty much the limit. Sunburn is all about prevention. Once you get it, all we can do is provide symptom relief. And a bad case of sunburn could take you off daytime watch duties for 3 to 4 days. In the past, we used to advise getting gradually accustomed to the sun, but we've since changed. We were mistaken. No, capital N-O, do not get used to the sun. Do not prepare for deep sea voyaging by getting repeated mild sunburns as part of your training. You should be practicing obsessive protection from the sun. Get comfortable and habituate using the proper protective sunwear and the proper sunscreen. Take it from the experts. Find proper well-fitting polarized sunglasses with tethers and bring an extra pair. Find a wide brim hat that breathes and figure out some way to clip it onto you. My personal history, I've lost over 6 hats. And some of them have a lot of sentimental value because it gets windy out there. Get comfortable with some kind of upper body cover that breathes, like a long sleeve t-shirt, a sun shirt, or as you can see here, ad-lib with a pareo. And then prior to departure, experiment with different, and this is very, very important, different reef-friendly sunscreens. I've already made the switch. It's law now. It's law soon, so you might as well get used to using reef-friendly sunscreens. Apply them generously. Now, these are 2 pictures of the Rothman brothers. They're professional surfers on the North Shore. And I chose this picture because these guys are not wearing makeup. They have a sunscreen. Apply it generously. The fairer your skin type, the more you should apply. And don't forget your ears, your lower legs, the tops of your feet. And don't forget SPF chapstick for your lips. You can't use sunscreen on your lips. The other reason for reef-friendly sunscreen is all those chemicals, not only do they mess up the wildlife and the reef, but they also absorb into your bloodstream. So all the more you don't want to use it on your lips. Diet preparedness. I've learned, I was taught, and I ignored it, but I've since learned that there are three topics you shouldn't talk about unless someone invites you to discuss it. Don't talk about religion, don't talk about politics, and don't talk about nutrition. You want to see a big argument, get a low-carb ketogenic diet enthusiast in the same room as a vegan and stand back. Now, if you are unforgivingly inflexible about the quality of your diet, you probably should not sail because you're not going to be getting 5 servings of fresh fruits and vegetables a day. Our advice in preparing to voyage is to eat what you expect to eat on the canoe. Don't go on a special diet to cleanse yourself prior to departure. Don't go on a fasting program or something like that. You know, get an old diet menu from a previous sail and see what kind of stuff they're packing. And you should probably start eating like that a week or two, at least a week before you go. If anything, you want to see how your body responds and how your bowels are going to respond. You know, if you have a medical condition that relies on a therapeutic diet, you want to see how you're affected. So example, guys with diabetes and hypertension, you want to see how your biometrics respond to the canoe diet, keeping in mind that when voyaging, your portions and total daily calorie intake drops while your physical activity literally doubles, so that you're going to be in a calorie deficit. And that compensates for the increased intake of processed foods, sugar, and salt. If you're on a really, really strict prescriptive medical diet, one that is quantitative, you know, if you got kidney failure and you're on a 40-gram protein diet, you got kidney or heart problems and you're on a potassium restriction, magnesium restriction, a salt restriction that is taught to you in grams, something that restricts electrolytes, minerals, or fluid, you know, you probably should not be sailing. Then the risk becomes benefit, at least deep sea, maybe something coastal. But again, if you're on a quantitatively prescribed diet, that's something you really need to consider if you're invited to sail. Now, the canoe diet is not a haphazard one. When I look back at what we had in '92 to what we had when I last sailed, there's been a huge world of difference. Dietitians are involved in planning for the food. The canoe diet is not unhealthy. It is not a high-fat diet. I dare say it's nutritionally more sound than what the average family consumes when they go camping at the beach. Otherwise, what we bring is limited by storage space, weight, water restrictions, lack of refrigeration, shelf life. They do take into consideration how much garbage is going to be generated, but also ease of preparation and familiarity. One size has to fit all. And there's a lot of variation when it comes to food and taste, food taste. So again, they're very conservative in picking what they think most people can live with. Freeze-dried and canned vegetables are supplemented when fresh vegetables run out. So it's not like you're living off of, you know, Vienna sausages and Spam and white rice. No, the diet is pretty well planned out, as you can see from that picture. Now, I'm not going to review the menu, but again, you can ask for a sample one. Of course, if you catch fish, it's a blessing. That throws everything out the window, and that you can live off of. Water restriction. It goes without saying just how valuable drinking clean water is on the canoe. But water takes up a lot of space and it's very heavy. Probably one of the top 5 things I've learned since I first started sailing with PVS 1992. And the thing that is still stuck with me to this very day is just how fortunate we are to have clean, tasty water. It is a luxury. I sort of get insights into how much I take it for granted, and I always get a lot of insight into just how much I waste. Don't do that. Now, as relates to water restriction on the canoe, do not prepare for voyaging by training yourself to endure dehydration. Things don't get that bad. Each person usually gets about 1.5 liters. That's about 1.5 quarts. That's about 3 pints. That's about 6 cups. So everybody gets about 1.5 liters of water a day, and that's adequate considering that you're not going to be doing as much sweating as you are on land. So you might want to practice on 1.5 to 2 liters a day for a couple of days just to see what happens to your bowel habits, how dark does your urine get, and how do you feel. Now, if the taste of water is important to you, because they do treat the water with chlorine in prescriptive amounts, you might, if you know, taste is important, you might want to try out various sugar-free products that you can add to flavor your water. But just be careful. Don't make it too sweet because you don't want to be chugging water because it tastes good. If taste is important, bring some hard candy that you can suck on instead. And again, you just want to bring something to kill the taste of the chlorine in the water. The next section, probably the most important one, and I found some really gross slides on this one, but I decided not to use them. It's bowel training. It's about constipation. Constipation on the canoe is very common. No one likes to talk about it, but if I had to take a guess, I think 80–90% of the crew is affected by it at some point in time. This is where prevention comes in, preparation comes in, practice comes in, and knowing thyself comes into play. You know, if you have parkopresis, if you're the kind of person who has a shy bowel and values privacy when it comes to going number 2, you might fall victim to modesty-driven constipation at sea. I did. Now, you can prepare for this by practicing desensitizing your self-consciousness by going number 2, where others might hear you or know what you're doing. Now, the canoe is extremely respectful about visual privacy, okay? No one's peeking or doing anything like that. Visual privacy is not an issue, but at least on Hokulea, sometimes you're going with somebody literally inches away from your head, yeah? I mean, you can hear the guy above you cracking his knuckles. You're wondering can he hear about you? That's the kind of stuff that makes things just clam up. But you can practice and desensitize yourself to this kind of stuff with a little bit of deliberate training. Example, in the weeks before you go, don't go number 2 at home. If you do, don't close the door completely. So whoever walks by makes a wisecrack. It's your house. You have a right to leave the door open if you want. But if you practice at home like that, you'd be surprised how quickly you desensitize. Another something I used to do is before sailing on weekdays, I would only go number 2 at work. I would not do it at home. There's a hassle factor there, but it did work. And then on the weekends, I would usually find a safe public restroom at some local city in Kearney Park. I went to Kohala, Kamiki Park, Wailai, Kahala Beach Park, and once I went to Ala Moana. Yeah, there's no doors on the stall there. So you just practice go number 2 there. Make eye contact when the guy walks by you. You'd be surprised how their eyes turn away from you and you're actually afforded a lot of privacy. But that really teaches you to desensitize your bashfulness. And that goes a long way on the canoe, trust me. Something else that helps, and we found out a lot of people kind of put off going to the bathroom for as long as they can. You kind of don't want to do that. So in the days leading up to departure, you want to start pushing high fiber foods, hydrate really well. You want to get going regularly because the goal is you want to try goal number 2 the first day you're at sea. You don't want to wait 3 to 4 days and then try. You know, the first time is going to be hard, but the second time is easier. The third time is easier after that. So again, the whole goal is get going as soon as you can. A general rule of thumb there is whatever your land-based habit is, multiply by 3. And if you break that time frame, let the doctor know. If your usual habit is 1 day, if you go more than 3 days, ask for help. If you go every other day, you know, after 5 or 6 days, you should let somebody know. Now, something that worked really well for me was to plan ahead of time and plan for a large communal container of punmui. Now, I don't know the recipe for this, but it's usually a mix of prunes and dried mango, rock salt plum, wet lemon peel, apricots, lemon juice, salt, water, and sugar. And it works really well. You can have a little, you can have a lot, and it also tastes good. That also helps. And of course, it goes without saying, you know, in the weeks prior to departure, practice with different natural remedies. Practice with different over-the-counter products at home. Find one that works. Figure out how long it takes so you know if it's not working for you, and how severe it takes and how long it lasts or it starts to fade. And then bring a personal supply for yourself. This is why we say know thyself, practice. Know how your body reacts to this. And examples are, you know, walnuts, prunes, dried figs. There are a lot of herbal teas that also act as laxatives. One word of caution, be careful about powdered soluble fiber products. Things like Metamucil, psyllium seed, ground flaxseed, any kind of bran or chia seed. These do not work well under conditions of water restriction. That's a good formula for concrete. They can make things worse. You need propulsion. You don't need solid volume. So again, I would avoid things like Metamucil or bran, because you're not going to be able to push the amount of fluids you need for that stuff to work. Now, as Dr. Seren said, we bring all kinds of stuff on the canoe. So if you do have a problem, ask us. Don't wait more than 3 times your usual habit on land. Common soft tissue overuse syndromes. Yes. Now, if you have issues with recurrent trigger fingers, decurved veins or wrist, thumb tendonitis, tennis elbow or lateral epicondylitis, golfer's elbow or medial epicondylitis, chronic shoulder pain, rotator cuff injuries, restricted range of motion, hip bursitis, butt, thigh, back pain and stiffness, especially if those issues have compromised your physical function on land in real life, you should consider seeing someone who's comfortable with physical therapy, primary care, or sports medicine. Because there are conditioning, mobility, and strengthening exercises that you can do to toughen those soft tissues up and to help prevent flares on land. I know for trigger finger, which is what I used to get, there are all kinds of gripping things you can do and build up over time. And that way, when you're grabbing and squeezing and pulling on stuff, you don't have problems at sea. Again, you want to start your training about 2 months prior to departure because it takes time to toughen up soft tissues. Now, if you don't do that and you do have problems, ask the medical officer on board. We have meds you can take. We can even inject stuff. So don't try and tough it out. That's just going to make it worse, and you might actually hurt someone else, like dropping an anchor on somebody's foot. This part here, it's about behavior. Behavioral preparation for living in tight quarters. This is about tolerance training. And this is something, again, you can deliberately practice for. Now, I'm not talking about claustrophobia. This more has to do with having the need to be physically distant from another person. This means getting easily annoyed or impatient with somebody who's on your crew. Here again, know thyself. Get to know your crewmates during training and be honest with yourself. If you think there's somebody you might not get along with, talk to your captain, talk to a senior member of your crew that you trust, talk to your medical officer, call one of us. Because again, there are things that can be done to help you adapt to stuff like that. It's not a matter of right, wrong, who's at fault, who's not at fault. It just is. Again, talk it out. That's what we mean by be honest with yourself, know thyself. Now, you can consciously practice tolerance and patience towards others by deliberately seeking out others who embody the behavior that irritates you. Yeah. Practice not getting your way. Allow yourself to lose an argument, even though you know you're right. When you're on the freeway, drive in the far right-hand lane and let everybody cut in front of you. Listen to the news on a station you disagree with politically, so you never watch them. And don't make any wisecracks. Regularly spend a lot of quiet time out in nature before you go. That works magic, and you'd be surprised what that helps to do in terms of settling you. But this is also very important because once you're out there, I guess they could have somebody go stay on the escort boat, but you kind of don't want that if you have 2 canoes. So again, prepare yourself, know thyself, be honest. Prepare yourself behaviorally. Okay, seasickness. You can prepare for this. Dr. Seren talked a lot about this. The best advice I can give for preparing for seasickness is to know yourself. How do you handle seasickness? Are you the type of person who does not accommodate and does not adapt? Most people get better after 3 to 4 days, but if you're the kind of person that is sick the entire trip for the whole, a week or so or something like that, you're gonna have to do some homework. You might want to train with somebody who's got a monohull and actually desensitize your sensitivity to motion sickness. Otherwise, you might want to search for meds or supplements that work best to control your symptoms until you adapt so you can function. There's no formula for this. It's pure and simple trial and error. Ask others what works for them. Ask others what they do. We had one crew member where no prescription med, no over-the-counter med worked. She found out about this drug that is approved in Canada, the United Kingdom, Southeast Asia, and Europe. It's not approved by the FDA for use in America. So we got a supply from Romania, and it apparently works for her. The Royal Navy uses it, just America doesn't have it. So you can ask around if there's something that does work for you. Now, this is where home remedies work. I'm a big fan of ginger, but a word of caution, ginger candy doesn't work. You have to get as Papa Henry told me in 1995, you got to get ginger from the right valley, and you have to process it as minimally as possible. He also mentioned, I remember telling me about certain strains of Olena. Again, I don't know where, but again, certain valleys have it. And they would process it into some liquid that you would drop into your ear. And he said that was probably the best remedy he knew of. But again, we can't give you advice like that. You got to do your homework and talk to a traditional healer, a kahuna or some sort, and find out, and then try it and see if it works. Now, we had a bunch of questions about transdermal scopolamine. We do really try and bring a stock of our own. That has to be put on 6 hours before you go. But again, it's not for everybody. It doesn't work for everybody. It's not something you're going to keep on the entire trip. It's not something you change every day. You put it on 6 hours prior to sailing. You take it off and change it every 3 days. But men above age 50, you need to be careful, because we did have a case. This guy was about 62 years old. He put on the transdermal scopolamine. He never tried it at home. He didn't practice. He just used it the first time about 6 hours before departure. And he didn't go pee the first whole day, and he had to go. He couldn't go. He had an enlarged prostate, and the thing made his prostate sphincter spasm. So we took off the patch, and if he didn't pee in a couple hours, we're going to have to stick a catheter in him. And after about 6 hours, he went. That was kind of scary. That was the closest we came to having to pull out the catheter and use it. So again, older men, be careful. It's okay to try it, but if you got a heart condition, if you have an eye condition, there are a bunch of things you have to sort of get cleared from. A prostate condition, you kind of don't want to use it. There are contraindications. You have to be careful when you do use it. Now, when it comes to seasickness, what actually worked best for me was along the lines of high altitude sickness, and I get really seasick very easily. Yeah, with high altitude seasickness, you acclimate slowly over several days. So what worked for me was I would always volunteer to do canoe watch for the 2 to 3 days prior to departure. And I would sleep on the canoe overnight for several nights prior to departure instead of spending the last few days on land. And what it did for me was I would sort of get a little bit queasy those first couple of nights, but usually by the third night, I was fine. I was sleeping fine. I got to the point where when I would get off the canoe and stand on land, the land would be moving while the canoe sitting in the water was still. That means you're acclimated. So again, that worked for me. I don't know if it's going to work for you. That's where trial and error comes in. Family and domestic issues. This is a hard one to talk about without feeling like someone's judging you. This is a really touchy issue. So all I can say here is, the clinical work I do, I work with obesity, and virtually 90% of the patients I see are patients that are going on to bariatric or weight loss surgery. And what I tell them about bariatric surgery is that weight loss surgery makes good relationships better. It makes bad relationships worse. And most of the time, it doesn't do anything for the average relationship. So the same thing with voyaging. Voyaging is not going to fix something personal in your life if it's not inclined to be fixed in the first place. If something is not going well and you want to preserve it, leaving home to go sailing is not going to make it better. Absence does not make the heart grow fonder. Absence makes the heart fond of absence. So long distance voyaging is not a good interventional tool to improve whatever kind of stress you're having. It doesn't work. It almost always makes things worse. Sail as crew when the time is right. Home, family, and life are much more important. That's pretty much all I'm going to say about that. So this is where Dr. Mao was supposed to come in and do her talk. But I'm going to jump to my last section here, which is about travel medicine. Nope, that's the old one. Okay, wait. Here it is. Okay. This topic involves health and safety issues related to traveling away from home. It focuses on acquired infections and exposures to risks that are endemic, you should know what that word means, at the given destination. What details of what I review are not important, so don't take notes on this. We're going to go over this before you sail. What's important from this section here is seeing the importance of prevention, preparedness, and practice as relates to health and safety. Now, some of the risks at the destination sites around the Pacific Rim and in the Society Islands, some of those risks can kill you. Some of them can just maim you and go on affecting you for the rest of your life, like malaria. And the rest of your life is a long time for you and your family. So again, you want to take this thing seriously when the time comes. And again, I stress, we're going to go over this topic again in real time with actual crews, depending on where your destinations are. And it's a specialized topic. This stuff is changing rapidly. So we're probably going to bring in experts for detailed advice for specific crews when the time comes. So food and water precautions at destination sites. Now this relates not only to travelers' diarrhea, but diseases like salmonella, shigella, typhoid, and other transmissible bacteria, viral and parasitic diseases. Now this is real life. Within a 5-year time span, I had the husband of a patient of mine die in Republic of Congo from typhoid. He did not take prophylaxis. He went up. He had diarrhea. He got sick. In 3 days, he was in the hospital and he was dead. And he had salmonella, a really virulent strain in this day and age. So again, tropical medicine is an important stuff. It meets Murphy's Law, yeah? So some general rules of thumb about water. Stick to bottled water, but sometimes you can get guys faking sealed caps. If you're going to use bottled water, always check for an intact vacuum seal. Otherwise, stick with carbonated beverages. And be careful with ice cubes and brushing your teeth. And just because you're drinking an alcoholic beverage doesn't mean it's safe, because the kind of alcohol you drink is not the kind you use to sterilize surfaces. You can't wipe doorknobs with beer. So just be sure the beverage you're drinking came from a factory sealed bottle. And again, careful of the ice tubes, as they're usually made from tap water. Regarding food, stick with cooked foods and factory sealed packaged foods or canned goods. Careful about salads, fresh fruits and vegetables, unless you trust the source and unless you trust the preparer. Go online and look up night soil, and then you'll see what I'm talking about. Now, if you can't peel or wash it yourself, don't eat it. Now, be careful about any kind of exotic bush meat. If somebody comes up to you and offers you a monkey brain omelet, I don't think I would have it. Just say no, thank you. That's probably where HIV came out of in the 1950s in the Congo. It was probably transmitted from bush meat, monkeys. Now, if you're worried about traveler's diarrhea because you've had it before, we can pre-medicate you with Pepto-Bismol tablets. We do carry a supply with us. Otherwise, you should come prepared, and no shame, bring your own meds in case you get it. Now, as it relates to traveler's diarrhea, the incubation period from a culprit meal is usually about 6 hours to 48 hours after you eat whatever's, gave you it. And we do stock several kind of oral antibiotics and loperamide in generous quantities that we can treat it. I had one crew member just not say anything, and he was shamed, and that's unnecessary pain and suffering. Just talk to your doctor. We can treat it, and it'll be done with. Vectors, things that carry stuff. Yeah, insects and animals. Mosquitoes are at the top of the list. In fact, in some years, mosquitoes kill more humans than humans do. Malaria, dengue, chikungunya, Zika, yellow fever, and many types of mosquito-borne encephalitis. Encephalitis is inflammation of the brain. That's deadly serious. This is where practice, prevention, and preparedness are critical. Protect yourself with the right clothes and apply repellents to the exposed skin. Now, the repellents you should use on your skin should only be one of 4 CDC recommended chemicals. The first one is DEET, and whatever you use, it should be 20 to 30% DEET. We have a handout for this for crews, so again, don't take notes. We're going to give you a handout in preparation for your actual departure. So you are going to have DEET, 20, 30%. You can also use picaridin, no less than 20%. There's also something called IR 3535, Skin So Soft, 20%. And this is the one that I use when I do yard work, oil of lemon eucalyptus should be 30–40%. At least it smells good. Proper clothing. Proper clothing is not enough. Mosquitoes have been documented biting people through denim, although that's rare. So your clothing has to be treated with a permethrin-based repellent. And even then, you still need to apply topical repellent on your exposed skin. We usually advise 2 sets of land clothes, long pants, and a long sleeve t-shirt, and long shorts with a short sleeve t-shirt. Spray treatment of clothes is really the best way. There are things you can buy and soak your clothes, but you have to wear gloves. Spraying is a whole lot cleaner, a whole lot safer than actually buying it in volume and soaking your clothes and then hanging it up to dry. That can be pretty toxic. You can also buy pre-impregnated permethrin-treated clothes, but it can be a little bit expensive. Dogs, yeah, poor little stray dog. Yeah, poor little stray hand. For that matter, poor little stray cat. Dog bites destroy a lot of tissue. And then again, there's rabies. Cat bites and cat scratches can also be very, very serious. Arguably, they're more dirty than dog bites. Not to mention the risk of bringing fleas back to the canoe or wherever it is you're staying. So again, careful of stray animals. Now, there is a vaccine for rabies, but we usually don't give it unless you're at high risk, like a part-time veterinarian or something. And if you do get bitten or scratched, there is a treatment that can be given after the fact. It's a series of injections of antibody. You have to go to a local ER or a local urgent care clinic. And again, the danger there is they may not stock it. So that's why you just, again, prevention is everything. You don't want to take things for granted. And also prevention is worth a ton of cure. Snakes, outside of the obvious risk of being bitten, these guys are really sneaky. And if a raccoon can get into the canoe medical supplies somewhere off the east coast of Georgia, there's a fair chance that a snake could make its way onto the canoe if we're not deliberate about prevention. Spiders, we never paid attention to this stuff before, but spiders and other stinging and biting insects also require some preparation. We did have a brown recluse spider bite in a crew member when the canoe was off South Carolina on its way to Florida. The crew member thinks she got bit in bed. She felt a little tickly, burning, itchy sensation on the side of her hand, and she just sort of brushed it away. It was really trivial. She never saw a spider. But again, this brown recluse spider is really, really small. A day or two later, she started to get pain and burning. It went up her arm, and it got worse. And this was about the 3rd day. And then over a week, it gradually progressed and faded. And it healed. Now, this spider is in Hawaii. It is in Hawaii. It's rare. And depending on how your body reacts to the venom, the wound can actually get pretty gross. I have taken care of patients with brown recluse spider bites about a foot in diameter on their thigh. So again, it's not something you really want to screw around with. There's not much you can do except be careful, be vigilant. Don't just jump into bed. Toss out the sheets, check things out. Look for bed bugs and spiders around you. Anyway, now, brown recluse spider bites, although they heal, this is the same crew member 4 months later, it had healed, gone away, and out of the clear blue sky, it flared up without any cause. And then it went away over about a week. It was thought to be an immune reaction to the venom. Box jellyfish and saltwater crocodiles in the Indo-Pacific and along northern Australia, again, PVS is very good about this. They know what to do. They do take precautions. But again, just wanted to throw that in there. The species of box jellyfish is different. It's much more toxic than what you see locally. And finally, the most deadly species on the planet, mosquitoes included. I didn't know cows was for North America, believe it or not. But actually, this is a trick question, yeah. The most dangerous species on Earth are humans. Be vigilant of what the crime rates are where you're going, where to avoid, Don't get adventurous and go exploring places off on your own at night. You got this big bullseye on your back. Common sense goes a long way towards prevention. Listen to your captain when you're on shore. So some basic quick things about travel vaccinations. This is sort of the menu that we choose off of, basic travel vaccinations. Tetanus, that needs to be up to date. Influenza annually. Hepatitis A, unless you've already had it. Typhoid, it's a pill, it's a shot. It depends if you've had it before. It's pretty standard now, and it depends what you had and when as to whether you need a booster or not. MMR, otherwise known as measles, mumps, and rubella. If you're born in 57 or after, it's relevant. If you're born in 56 or before, it's not. Now, yes, I know there's controversy. I know some people don't like to get vaccinations. But we worry not only about a crew member getting measles, but when it comes to measles, keep in mind it affects adults differently than children. But more importantly, we worry about a crew member bringing it into a destination. You all heard about what happened in Samoa last year, not to mention the historical record of what measles has done to the Hawaiians. Yeah, 500,000 dead in the 17 and 1800s. It's not something to mess around with. Same theme as varicella or chickenpox. Now, if you're born in 1980 or after, that's where we need to ask you questions. Did you get it? Did you have the vaccination? Prior to 1980, odds are you've probably been exposed and immune. But here too, Patsy Mink died in the early 1970s at age 74 from complications of chickenpox. I don't know how she lived her whole life without getting chickenpox, but she did. So again, it's not something, it affects adults differently than kids. Now, each specific destination will have specific requirements and precautions, yeah? Dengue. During the worldwide voyage, a vaccine did not exist, but there is one now. We don't use it much except for people that have already had dengue once. You know, there are 4 strains of dengue, and it's usually the second infection where the immune system is already primed to go that people get really nasty side effects, and it can be fatal. So again, if you had dengue once, you may want to talk to somebody about a vaccination because the second infection is usually very dangerous. Otherwise, most crew, it's just mosquito prevention. Polio. The worldwide voyage, Madagascar had a polio epidemic as we were sailing toward it. We've had a sort of insight from one of our advisors, Dr. Ansdell, that be on the lookout because Madagascar is going to have a polio epidemic, and sure enough, they got it. So we did vaccinate crew before they left. And then last minute, for other reasons, they decided to bypass Madagascar. So that's okay, no harm done with the polio vaccine, but it's something we will be checking on because there have been outbreaks throughout the world of this. Yellow fever, about 15%, 10 to 15% of people who get yellow fever get severe disease with complications, and half of those people die. So it is something we do take very seriously, and there is a vaccine against it. Now, logistically, yellow fever vaccination is important if you're going to a place where it's endemic. I think parts of Peru, parts of Colombia, and parts of Panama, it is required by the CDC. And if you're traveling to these places, many times immigrations won't let you in unless you can show them paperwork and a certification that you've been vaccinated. Also, if you're leaving from a place that has yellow fever, your destination may not let you in because if you don't have that vaccination certificate. So if you're going to a place where it's a concern, you need to get vaccinated or you don't go. Now, during the worldwide voyage, the sail plan did avoid areas where yellow fever was endemic. And last I heard, the vaccination was good for a lifetime, but we're going to have to check on this. Malaria, we're almost done. Most of you on the worldwide voyage, in Africa, parts of South America, Central America, we have to put on malaria prophylaxis, Indonesia. And we did hear about non-compliance with the meds that kind of went beyond having side effects. That's understandable, but it is something that gave our med advisors some heartburn, especially if you consider that for a lot of crew, we don't expect 100% compliance with mosquito repellent, let alone treating your clothes with permethrin. We used to do it as a crew, but after the first third of the worldwide voyage, we stopped doing it and kind of left it on the individual crew's initiative to treat their clothes. So we understand that kind of stuff, not 100%, but I want you to take a scenario into consideration. Say you're on a crew and you're departing from a city that has CDC advised malaria prophylaxis posted. You don't take your meds. You didn't treat your clothes well, and you're kind of lax on applying repellent. So you spend a couple of days and a few nights on land at public events. You may excursion, go into the wild for some hikes and stuff like that. go into the community. You know, you say your goodbyes, you get on the canoe, and you're off. About a week later, you start to feel a little bit sick. Yeah, you get this headache, a sense of nausea. You feel weak. The next day, you got shaking chills. Your T-shirt is soaked. The temperature is 105. You're nauseated, vomiting. You're confused. You're not making sense. You got diarrhea, abdominal pain. You're so sore you can't even get out of the bunk. You're curled up in a little ball. That's malaria. That's a medical emergency. The cell plan shuts down. The cell plan shuts down because it can be life-threatening. So again, prophylaxis is very important. We can be prepared, but if you don't execute on prevention and practice, stuff can happen. A word about body fluids and human-to-human contagion. This is HIV, hepatitis B, hepatitis C, sexually transmitted diseases or illnesses, and lice. We usually don't do pre-departure hepatitis B status checks, as we don't routinely vaccinate against it, unless you're at high risk of exposure, such as a hands-on healthcare provider. HIV, you know, HIV is a pandemic. It's in the same status as the coronavirus. It's been around since 1981, and I didn't know this, but since 1981, HIV has killed 37 million people worldwide, mostly in sub-Saharan Africa, India, and Southeast Asia. So it is something to take seriously. There's no vaccine against it. It's all about prevention. You want to know the risk statistics of the destination you're going to. Now, you know, Thailand, for example, 1% of the population carries it. And if you go to the big cities, only about 3/4 of the population are on meds. In rural areas, they're not. So again, Thailand, you need to be careful about HIV. You can't tell if someone has HIV by looking at them, yeah. And then finally, for the SARS-CoV-2 virus stuff, it's far too early to say anything about it. It is in the Pacific Rim, it is in the South Pacific. We're gonna have to do research on the destinations when that time comes. I think that's it. So from here, I'm gonna pass it on to Dr. Kelly after I get out of here.
Okay. Okay, let me just see if I can share this screen. Okay, here we go. Okay, so the next section is sort of emergencies at sea. We're running out of time, so I'll try and be quick. The main issue here is at sea, like I said previously, our medical supplies are pretty limited. There's a lot of medical emergencies, surgical emergencies that we're not going to be able to take care of. We don't have oxygen on board. If someone gets severely hypoxic, we will not be able to oxygenate them. We don't have any cardiac monitoring. We'll be able to do some things, but we won't be able to take care of, if anybody, if their heart stops, there's a good chance we won't be able to start it up again. We won't be able to intubate people. We won't be able to do any kind of critical care on board. So we just have to understand that those are our limitations at sea, and if there is an emergency, we won't be able to fully manage it on the canoe. So we will have to do our best to evacuate the crew member. So if there is an emergency at sea, we do have a protocol that's been in place in the past, and we do have something right now, but I'm sure will be updated. Also, the protocol varies based on where we are, if we're near land, if we're way out at sea, and it will vary based on where we are in the world. So initially, in the event of an emergency, the captain and escort boat will coordinate. A mayday call will be sent out if we need to get somebody to help evacuate a crew member. We do have a satellite phone on board, and we will contact the executive team. They have their own emergency protocol as far as communication. One of those things is to coordinate with the U.S. Coast Guard. Now, if we are within 100 miles of U.S. coast, we'll hopefully be able to get a Coast Guard cutter to help render aid. If we're not within that, if we're not in that 150 miles, We have had in the past agreements with the Coast Guard that they will help find us a larger vessel near us that will help to evacuate us, or they will help coordinate with other Coast Guards around the world. While on the canoe, we'll try to head towards the nearest port. If we are able to flag down a faster boat to help us, or if we are able to get the Coast Guard to assist us, if the person needs to be evacuated, we will attempt to evacuate this person towards the larger vessel. Also, if we need to evacuate the person and we by air or by helicopter, Seren and the previous crew that went to the West Coast and a little bit colder water sail, they came up with a plan to get the crew member off the boat. Because of the sail, because the mast would interfere with any evacuation straight from the deck of the canoe, the person would be placed in a life raft, and the rescue swimmer will take that person out to a safe radius to evacuate the patient or the crew member. Also of note, in the past, the medical officer would accompany the crew member. Most of the time, this is going to happen. Of course, if the person was being evacuated to a larger vessel that actually had a physician on board, then we would have to discuss this with the larger vessel and also with the executive team. If we are able to travel to port and we do, under our own power, go to the nearest port, the crew member would be taken to the nearest ER or appropriate hospital. And in that case, the medical officer would go with the patient to assist with interpretation and also with the medical care of the patient. Okay. One other thing that's important. So your medical insurance, HMSA or Kaiser, whatever you have, will most likely not cover the evacuation fees, the repatriation of the crew member, or oftentimes any medical care given there. So we expect everybody to purchase Divers Alert membership at baseline, at the very least, because they have a benefit, a repatriation and a medical evacuation benefit. This is important. If you get sick in another country and you need to be evacuated to a developed country or more appropriate medical center, the cost of this could be in the hundreds of thousands of dollars. So yeah, this is a good idea to have just in general, even without being a crew member, but it's mandatory for our crew members. Sorry. Yeah, so that's basically it. I mean, the main issue is just to know that there is a protocol. We have one in place. We will most likely rework it and modify it going forward based on where we are traveling, where we're voyaging, and based on what type of emergencies or what type of medical problems that we would expect or could possibly encounter based on a certain voyage. Okay, so I'm going to hand it over to Seren now. After I can stop sharing. Okay.
Share screen. Okay, hold on, I gotta find my talk. Yeah, okay. Okay, so this is just real quickly safety on land. And Ben actually just went over most of this stuff, so this is gonna take just a couple minutes. But most important thing when we do arrive elsewhere is respect, respect, respect. You're an ambassador when you're in another country with PVS. So your actions are representing yourself, our crew, and our community at home. So try to be as conscious of that as we can be. Listen to your captain, listen to your medical officer. Be where you're supposed to be when you're supposed to be there. Crew calls are often set up and the expectation is you're there when you're supposed to be. Take any travel medications as directed. Please, no throwing medications overboard, please. Ben just talked about this, but I mean, malaria sucks. Don't be this guy. Know your environment ahead of time. So for example, in the Marquesas, if you see a beautiful empty white sand beach, don't go frolicking through it without asking others first. There might be a reason why people aren't running around there. Those are sand fleas. Review food and water precautions with medical officer. There's a lot of interesting cuisine out there. Some things we might discourage you guys from eating due to safety concerns. Recreational sports. Be careful about recreational sports that risk injury. Generally, try to avoid competitive activities, hyper-competitive activities. Resist the temptation of, for lack of a better term, showing off to others. No dunking on kids. No charging these monster waves at Chopu. Please don't give your medical officer a heart attack. Tattoos is something that did come up as being important to talk about. So Mike Tyson once said everyone has a plan until they get punched in the face. So similarly, everyone thinks that they won't get anything from getting a tattoo until they get hepatitis or HIV or some gnarly tattoo infection. And relationships. STDs are real. Pregnancy is a real thing. So please take precautions if you decide to enter into any sort of a personal relationship with anyone. And I think that's it. That's all I got. Thanks, Kelly.
Okay, yep, here I am. Okay, so essentially, okay, Rapal, some closing remarks right now. The main issue is, sorry, let me this. I'm gonna share my screen, sorry. Share my screen, go there. Okay, some closing remarks. Essentially, just be personally responsible, okay? You're responsible for yourself. We're here to help you as much as we can. We'll do as much as we can possibly do, but you have to be responsible for yourself. Know your limitations, know the problems that you could possibly encounter. Try to plan for them as best you can. Try to prevent them as best you can. Okay, so like we talked about before, prepare as best you can, prevent, and when you've done that, practice as much as you can, so that when you get on the canoe, everything is as smooth as possible. And yeah, you don't give your health officer, your medical officers too much to do. Okay, we want you to be healthy. If we're not working, if we work super hard in the beginning and not so much on the boat, that's better for you. We want to be taking care of you as much as possible, but we'd rather everybody be healthy and safe. That's what this is about. Okay, so with that, I'm gonna open it up for any last closing remarks. So who do we have? Bruce, do you have any closing remarks? Is Bruce here? I don't know if Bruce is here. Okay. Ben, do you have anything to say?
No, sorry we went overtime.
Yeah, and Nainoa, do you have any closing remarks?
Yeah, really fast. I just want to thank the audience for participating tonight, because this is crew training. This is critical crew training, and I just want to thank the panel to help us really understand what it really takes to do long distance deep sea voyaging into many countries. And it's a huge responsibility, but it's really at the core of what voyaging is, and that's about caring. It's about caring for the canoe. It's about caring for each other. So I want to thank the panel for the amazing amount of information that we put into place, and we'll catch up with Marjorie next week, Tuesday, 5 to 7, and maybe I'll just turn it over to Lehua. She can give us the schedule for the next couple of sessions. But I want to thank the panel for taking all the time to be here today, but all the time it took to get prepared and being able to remind us how much it takes to keep these voyages safe. So when we say it's our priority, we're starting to kind of see what it really takes. And I think that's a very important message as we step into the future about looking at how do we make Hawaii a safe and healthy place, and what it's really going to take. And so thank you. Now I'll turn it over to, and Kelly, thank you. Maybe Lehua can close this with any thoughts and the schedule.
Aloha, everyone. Thanks for hanging with us through that, again, information-filled session. It is being recorded and posted. That link will be sent out afterwards, I think tomorrow, with a reminder. We are going back to 4 p.m. for Friday, and then back to 5 p.m. on Tuesday, trying to make sure that our medical team is still able to do all of their day-to-day work, as well as all the time they've taken to prepare these presentations for us. Dr. Tamura, sorry, I also have that survey that Kaukamau put together. Maybe we can include that in the follow-up email, really checking on some of the topics that you guys might want to hear about from the group. I know we haven't had a chance to get to questions. We would want to be respectful of time. And so I think similar to our first session, I'll collect the questions in the Q&A, and maybe we can work on them offline and maybe even revisit them in Tuesday's session so that we can get those questions answered for you. Anything else, Dr. Turner? Kelly or Seren? All right. But otherwise, I think we'll wrap this up so everyone can get off to dinner or sleeping or whatever it is in whatever time zone you may be. Mahalo nui for joining us, and we will see you again this Friday at 4 o'clock Hawaii time.
Okay. Bye-bye.